Hey everyone, this is the Nips and Sips podcast. Featuring me, I'm Dr. Jeremy Boyd, my partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about the good old Sammie, or called senior ass massage, in reference to treating potentially Piriformis Syndrome, or what some people believe is Piriformis Syndrome. I thought it'd be a fun topic to bring to the table, and we'll talk about the origination of the Sammie and go from there. But Brandon, how's it going?
Going well. Great name, great topic. I don't think this is limited to just piriformis syndrome, though. I think you and I have some good stories, anecdotally, and philosophies that will address it. It's early. It's about 8:30, 8:40 in the morning for this episode. I see you got the trifecta cup. Perfect, because I have the Pursue PT cup, King Thought. I have
King Thought.
cracking backs and dropping facts.
That's a good one.
Later on today, actually, I have a busy day. I have a AT concussion management course. Myself
Cool.
and recent grad, new hire, Anisha Varghese is going to be helping me doing a 4 to 5 hour course teaching ATs, basically manual therapy interventions, and kind of bridging the gap between on-field rehab and kind of return to play there. So that's why we have this early episode. I had my coffee earlier, so I'm drinking a straight up Noble Oak, and I know you switched it up today. No beer for you today. What do you have?
No beer today. Got a lot of things to do. A couple meetings later.
Yeah.
So, but I do have a little Bailey's in my coffee, and yes, you heard right. My cup does say King Thought. For some people, thought means that over there, or Thursday over there. Funny cup from a friend of mine, Nat. She helped me get things going at Trifecta, so guess I'm King Thought.
There it is.
But yeah, and also another acronym is the Sammie there, which was brought to by my mentor, Tom Michaels. I forgot how it came to be. I don't know if it was I was doing a couple in a row. That was kind of one of my, I guess, bread and butter techniques when I first got out of PT school. Was, poke the butt, oh, it hurts, and then it started going like elbows and fists deep, which has some, sometimes you need to do that. But he brought up, he's just like, how about those Sammies? I was like, what the hell are you talking about? He's just like, yeah, senior ass massage. And every time, like ever since that day, just hearing that's all I hear or see anytime anybody's working anybody's glute area. So just like and when we worked in a pretty senior, I think there was like 5 or 6 senior developments just were around our facility. So yeah, a lot of seniors, and he's like, sometimes I just want a good old butt massage. So that's how the name came to be. Props to Tom Michaels for bringing that to my life. But
so does that steer you away from doing those now? You just hear that voice in the
yeah.
back of your head?
I'm like, you know what? Let's just do some exercise or something. He used to, the best part of working with Tom, if he saw you doing something like that, or like the PA mobilization to the hip, you're kind of up in there, he would always take a picture, just from a cryptic angle, so it looks like your hand was halfway up the client's butt, and then you just send it out to everybody in the clinic. Yeah. He's like, Jeremy's having a good day. It's just like their butt and my hands like this. I'm like, yeah, so that made me think twice about. Yep. I'm like, do I really want to do this technique while Tom's here? Because you never know where this picture can come up. But yeah, it's always good to have a good, funny mentor with you. So, but yeah, Brandon, I know this is something that you wanted to bring up. I think you said you had a good case study. So
yeah, actually, it wasn't a case study.
Sorry.
We can go into those. No, it's cool. I saw, in our kind of show notes that you had mentioned Piriformis and senior ass massages and just the philosophy. This might be a little bit different, so I'm going to kind of segue away, but it's similar. But we're in Piriformis Syndrome, and what is it? Is it real? You might have the stat on this, Jared. What is it, like 5% or 3% of patients or people, I should say, their Piriformis courses through the actual Piriformis. Yeah.
Yeah.
Is that stat right? Is that percent
I
right?
think if it's
Something
like 3 to
that, right?
5% does sound pretty
So,
familiar. I'll look that up
so
while you chat
this
it up.
is a story. I was scrolling through Instagram, which is, I don't know, a gift and a curse, right? You see what other people post, you could comment, you end up getting in a little Instagram war battle.
You're the king of
Anyway,
that.
some jabroni. And I will say this, let me start, by bashing myself. When I first started, I used to do senior ass massages. I used to just pelt motherfuckers with a dry needle, pistoning them in their piriformis because it's a trigger point, and why not? It makes sense. You have to release it and elongate it, right? And whatever else the theory was. And Lord knows how many times I probably hit the nerve while I was doing that. But, you grow as a clinician. You evolve. You find out, okay, what is Piriformis syndrome? How is it caused? What is the why? How can I treat the origin and not just where the pain is? And that goes to many topics we've talked about before, regional interdependence, treating the origin, i.e. tennis elbow, i.e. Scapular or mid-trap pain, stuff like that. We're always preaching treat regionally, treat the origin. So with that was, something along the lines of this guy was saying the evidence on dry needling isn't out there, this, that, and the other. And I had made a comment saying he had posted 5 articles saying each of the reviews, and the bottom line was it was inconclusive or needs more study or it's only good for short-term effects. And one of my points in my response was, 2 of your articles look at heterogeneous, I guess, groups of people. One was dry needling, one was kind of electrostim, one was trigger point. All of them had different cases. One was dry needling for tennis elbow, one was dry needling for foot pain, one was dry needling for plantar fasciitis, one was dry needling for a different pathology. I can't remember all the top of my head. And it's just like, okay, how is a systematic review, which we're taught is supposed to be the highest level or one of the highest levels, you're going to take whatever 5 or 8 different diagnoses with however many different groups of people and then make this generalized conclusion that it doesn't work when you're using 5 different techniques across 5 different types of pathologies here. Like, let's dive deeper. Let's critically think, and maybe there's just, we can't lump everything in together. So that was my point. All right, so the owner of that page, whatever, didn't agree, and yada yada. That's fine. Yeah. Another response or another person's comment was how dry needling didn't help their Piriformis syndrome, and they had to go get an epidural for their back, and that cleared it up. Okay, great. So I asked them how they got dry needled, and they were like, yeah, at the Piriformis, so kind of equating to your senior ass massage to that Piriformis, just kind of digging in on that area. And my response was, maybe the person didn't dry needle the correct site. Just because they needled your Piriformis doesn't mean that was the correct way to treat that. You ended up getting an epidural to your back. Maybe your back was the origin of pain. Maybe if the person had dry needled your multifidi muscles or somewhere along, L5, S1, S2, or L4, L5, S1, you would have had a better response. And, it's like arguing with, the wall sometimes on Instagram. So they were like, no, it didn't work because my Piriformis is the one that courses through, pierces through the Piriformis itself. That's why the epidural worked. So at this point I stopped, but my rebuttal is going to be, yeah, there you go. Perfect.
So these are the different.
Yeah. So we have, here we go. These guys. What was it? My stance is, okay, this gentleman, I believe, was in his 20s, maybe early 30s, that had responded. And up to this point, your Piriformis had really never given you an issue all of your life. Why all of a sudden is it bothering you? It's not because it pierces through your body. If it pierces through your piriformis like that, it's probably pierced through your piriformis your whole life. If it didn't bother you all growing up, that's the fact that it's piercing through the piriformis is not the problem. There's something else causing it. You just happen to also have a piriformis or a nerve that goes through your piriformis. So again, leading us to treat somewhere else, treat the cause, not the site.
That was a that was confirmed by something.
Yeah, he had said it was confirmed via, I don't know what, ultrasound or whatever his doctor had told him. It was told to him by his doctor. Whatever the means the doctor used, whether it was an MRI or an ultrasound or whatever, was deemed that it was that. Unless the doctor was like, oh, it just may, I like I said, I stopped. But if you're saying your rebuttal is because you're having a certain type of pain because the nerve goes through the piriformis itself, you've had that your whole life. If this is your first time having this type of pain, that's not the reason. That's kind of my point. We need to think beyond whether it's using dry needling or a senior S massage or cupping or whatever other soft tissue, ART, or other active release techniques, Graston, instrument assisted, rock blades, whatever your means. Someone who has a piriformis syndrome. Well, let's dig a little deeper. Does that make sense? I don't know if I rambled or if I was able to convey my point across there, Jared. But
no, that's good rambling.
That's kind of my point. We need to really have a higher level thinking when we treat.
Yeah.
Honestly, the more I'm treating, I'll say the last thing here, Jared, and then I'll pass off to you because the more I'm treating, especially these vague type diagnoses, these syndromes, these itises, these algias, these apathies, the more I'm going more centrally to the neck, the T-spine, or the lumbar spine for a lot of things. And I'm having a lot of good results over the past, I don't know, eight months or so, with that. And, it took 5-6 years of practice to kind of get there and to really just keep questioning myself and talking about things. And by talking, I end up just reflecting. We have these conversations, obviously, weekly in our shows. You and I have side conversations, mentoring, this, that, and the other. So that's kind of my journey there. But yeah, I guess aside from Tom Michaels saying this to you, what has your experience been with Piriformis Syndrome, senior ass massages, and evolving your treatment and your plan of care?
Yeah. So that name was obviously given by Tom Michaels. He used to do it, and we laughed about it and those sort of things. But I came out of the PT program. It was with back being my weakest. I'll admit that it was like my
Spine
weakest.
Or back?
Huh?
Spine in general.
Spine actually. Spine in general. I mean, the cervical, and then
I didn't bother with it. That's why I want to clarify. I think that's most people. They're terrified of the spine. Yeah. I know I was first coming out. I don't think school really adequately prepares you for the spine.
It's it just wasn't. It was kind of, I don't know if it was rushed or anything like that. My school was big, as probably heard on the show before. Mackenzie was our thing for the lumbar spine and the cervical spine. Don't really remember much for the T-spine, but again, could have been me. I don't know, just not paying attention enough. I look back, I'm like, did we get this? And did I not just research enough? I can't remember. It was just a big fucking rush. But if I didn't have a repeated movement or repeated motions that didn't centralize or make pain better, I was really up shit creek without a paddle, so to speak. So I'd go in and, I'd literally just poke people's glute region. And if it was sore and uncomfortable or painful, I'm like, yep, that's it. I just need to blow that bitch up. Start off with my thumb, and then his knuckles, and then the fucking Egyptian elbow drop was coming down on people, and it would fucking hurt people.
That feels good though, right?
Yeah, and that's what they would say. I'm like, oh, then I'm on to fucking something, and then they'd be like, oh, it's sore, but it's not as bad. And every fucking what we look for, and we talked about in the show, or maybe I don't know if we talked about it, but it may have had a positive in-session change. I don't even know if it was, maybe I just made things so fucking sore that
They
people were
couldn't
like,
feel
I'm just
anything at
fucking,
that point.
yeah, exactly.
Or you just change the gated pain control theory and up
Yeah.
the threshold, and at that moment in time, they felt better.
And then as soon as I got home, or the very next day, or whatever next session I saw them, absolutely no change. And I was, again, I was almost getting, I can say I haven't really got physically tired ever in my, 6+ years of practicing. But probably back then, I kind of remember just like ass massage all over. Just trying to really kind of get in there and loosen that up. And that's when, again, and then on top of that was exactly what you said about the piriformis, like piercing through. It was like piercing through, and God, I feel so bad. I hope some old clients are listening in, because I always say that. I'm like telling my students and people I mentor, I'm like, a lot of the things that I'm teaching you took years to figure out. But all the people I had way back when, I feel so bad for them. I've unfortunately probably led them down the route of surgery, potentially even chronic pain, because I just, wasn't good enough. But always, if they had that soreness or those sort of things, I'm like, talking about it, trying to educate them. And that's kind of what I remember educating them. Like, some of these nerves pass through the muscle, and that can cause problems. And to plant that seed into someone's head was fucking, sorry, that was stupid. But that's education that I had to give to people. So
That was what you knew at the time. That was
exactly.
you were treating to the best of your knowledge at that time.
Yep.
Which is,
So
it is what it is. That's where we all are.
yeah.
We can't beat ourselves up for
Yeah,
it. We do,
I
but
did that.
but we do.
And that's what you're talking about with reflection, stuff like that. I've kind of talked about it in the show. I do like a periodic, like looking back at my intervention. So I'll just pull up random like cases from my EMR, which is nice because it's electronic, and look back, usually at one point I was doing every quarter. I'd look back every 6 months, every year. Now I look back every 6 months to a year, just randomly, and just look at what I was just picking as my intervention choices. And it almost all the time change. I'm like, I wouldn't really perform that anymore. One of the things, again, I can't remember the last time I went in on someone's piriformis at all.
Yeah.
It just, it got naturally weeded. It's still in the toolbox. It's just got a lot of fucking dust on it. So that one day it's like things like, maybe I just need to release this, or, do some sort of, mechanical stimulation to the area. But me actually spending more time, as you said, and that's something that clicked to me too, is like a lot of these people would get epidurals into their spine, and that would help out their piriformis syndrome. Well, if the true, I guess, impingement, encroachment, piercing, whatever the hell you want to call it, was happening at the piriformis, then why is that epidural really making an impact? I guess it has I'm sure has a, obviously a pain relieving effect, maybe neurophysiological, whatever it may be. But, it should be, interventions at the piriformis if it was truly piriformis syndrome. So, that's when, as you were saying, getting a little bit more proximal, understanding referral pain patterns. I know, Brandon, you have a good diagram of the lumbar spine, how each level correlates with some of these, areas. So, really investing into that really, really helped me. Then, yeah, I mean, luckily I haven't had anyone ask for one. I felt like at one point I was doing it so much, people were asking for it, so I fed into it even more. So maybe I just like giving senior ass massages. I just look back and I'm like,
yeah, that's all.
Huh? Yeah, that's it.
That's all.
I ever tell you the joke I used to say, first start PT school? How everybody asks, like, your professors are like, all right, just say who you are, where you're from, and why you want to get to PT school and or do PT. And I I would say, just to fuck with the teachers, I'm like, yeah, I just want to rub old men all day. And
God.
5 of 6 teachers, or well, maybe it wasn't even that many, I think I stopped midway through, laughed, had a good laugh. The whole class would laugh. But one professor, I did it, and it was a stone cold face. So it's like, I was like, oh, fuck. That's it. I was just like, that's it. I already got an F in this class. I'm screwed.
That's great.
I definitely did that for the first little bit. Looking at it, I mean, I started practicing in December. And thankfully, we got the lumbar spine and my cohort of residency in that first October.
Yeah, you started with the
September,
lumbar
October.
spine. You started in September. That was the spine.
Yeah, which was really helpful to me.
Yeah.
So it's September, October. So think almost about 8 to 10 months worth of good old Sammie's, dude. And I'm always kind of looking for what's the best option, trying to get people. It's a game for me. That's physical therapy. It really is just a game and a challenge. It's like, how can I get better? Something like this last time took me 7-8 sessions. How can I make that better? View it as a challenge, whether it's with education, manual therapy, exercise, timing of exercise, even reps and sets of exercises, focusing more on speed versus, pure strength and those sort of things, just kind of constantly evolving. And that's it. It's a game. And if you view it as that, to motivate yourself to continue to get better, you'll see certain things, just kind of fade away. And those Sammies did. Watch, I'm probably gonna jinx myself and have to get in there. But I still do some soft tissue work. I'm not completely throwing that under the bus, but yeah.
Well, I just kind of want to. Sorry, were you done, or I'll cut you off? I apologize.
No, you're good. You're good.
I kind of want to make a connection, and we touched upon it when you were talking with the gated control theory and just kind of pressing and that hurt that feels good. And this may not even be an intervention that we do, but a lot of people foam roll. A lot of people, especially, you have your athletes who do it, your CrossFitters, your weightlifters. And if you've noticed, a lot of them start with, they saw a white foam roller, then they go to the black foam roller, then they go to a ball or PVC pipe. Some of them even use the metal weight bars, the Olympic lifting bars. Now some guy has this Big Daddy thing or something where it's just like a 40-pound steel bar that you can buy and have it land you. And if you watch the progression, they're just going to a harder and denser material. What are they doing? What are you really doing? They're not solving anything, because every day they're still rolling the same areas. And if anything, they're rolling it with harder surface or longer, or both. And what are we really doing? In some respects, it may be good because you're increasing that pain threshold. Maybe it was here and now your tolerance is higher. So maybe on at one side of the coin, that may be a good thing. On the other side of the coin, what are you really doing? Are we just pushing that gated pain threshold higher and higher, that you just need a higher stimulus to get that relief that you usually got? Think of it as drugs. Hate to use the analogy, but
no, it's true.
Take some of those serious drugs, crack or heroin or something like that, or pills. They start with pills, and now that doesn't produce that same high anymore. They need more. And they either OD on something, or they switch to a different drug that's more powerful, like heroin, and there you go. So that same concept can happen with with treatment, and I'll include some of the stuff that we do, whether it's joint based, whether it's dry needling, whether it's neurodynamics. Are we just possibly pushing that pain threshold higher? Maybe not. But I just kind of want to throw that in there. Maybe if we educate our patients, hey, you can foam roll, but also just try throwing in a different intervention in there. Because if they're having to do it day in and day out, it's probably not as effective as they thought and think. So just want to throw it out there as a challenge to the audience to hopefully just reflect and try something new and maybe put a different set of lenses on to try and look through. So that's.
And I'd say, based off of what you were saying, and it makes sense with that pain threshold and those sort of things. That I've had, people kind of get hooked to what you're doing, and that's just me being like poorly managing them.
Yep.
And I had a
conversation.
Yeah, it's like maybe I prep them and explain how long, we're doing the manual therapy for, more educating about it, or transitioning to exercise quicker. Again, that's the constant, the game of trying to get yourself better. Yes, all the 50 people that you help with using manual therapy appropriately and those sort of things, you do run the risk that someone may, because you're giving them that little bit more of a pain threshold, they may get hooked, or again, that effect can be beneficial to them. And again, just like a drug. But yeah, so it definitely happened. And I was just thinking about a client that this is something for her shoulder. She's post-op and she was like reporting about pain here. And she was just like, I stuck things in, I tried to push it in, I tried ice, I tried all these sort of things. And then I had, instead of like what I would normally do, let me go in there, figure out what's going on in that area. I was like, well, what didn't you do? Of all the things you should try, maybe like stem, I can't remember. But what didn't she do? And I kind of led her to answer like, actually moved it, did something actively as her choice intervention. I was like, yeah, so next time that happens, I want you to try moving the arm, get it moving, try not to focus on it so much, or have a hypervigilance kind of process about it. And yeah, it went well. So just kind of knowing how to educate your people and that sort of stuff. But yeah, I figured I'd hop in on that little conversation. But yeah.
Jarrett, real quick, I just we're talking about manual therapy. I want to talk about that we had a question basically on how we use manual therapy. I'm trying to find where it was. Do you remember the what Trey Martin had asked? What section it was under? And
dosing.
How manual therapy was it under outcomes? I'm trying to think.
Yeah.
I'm trying to find it now.
But yeah,
because, so you were mentioning how you implement manual therapy and how it needs to change over time, stuff like that.
Yep. So someone in our mentorship brought up a question about how we dose our manual therapy. How does he do it? Like he was giving examples of how he uses it in his clinic or how the clinicians use it. But something I've found to be beneficial is, starting off things, as we say, we modulate symptoms, we can decrease pain, we can centralize symptoms, all these things to help get a buy-in. But then I gradually, start to do it less and less. A good thing is maybe a clock management almost, kind of looking at how you're doing it, maybe that first day or second session, and then just slowly like taking a minute or 30 seconds off each time. So it's just progressively getting shorter without, almost a client even realizing it, and then go a couple sessions and then, time's up and it's just like, all right, let's just start off, getting you on the bike or moving and that sort of stuff. So yeah, just some strategies to kind of funnel from, manual therapy and exercise into just exercise without just saying, hey, go exercise, it hurts. And then, we don't do anything for them. But yeah, that's kind of the gist of it.
Yeah, I think I had added with that response just, because he was saying how often do you still use manual therapy, or is it still a bulk of your treatment time? And aside from it depends one response that we typically get, it's just, you have to streamline what you're doing, find out, use test, retest on what works, narrow it down to the techniques that work. I had added in neurophysiological philosophy playing and kind of opening that window of opportunity for better muscle activation or better movement patterns and things like that. So yeah, it becomes, at some points, sometimes just a quick manual therapy that takes 30 seconds to a minute or so, and I still have the rest of the hour to do what you need to do movement wise. But I guess that's just kind of wrapping it all together for you guys here as well. This podcast, but actually just I can't find it and it's bothering me. Anyway, we'll wrap up with that. Unless you have anything else there, Jared, that you want to impart wisdom on.
No, I think that's pretty good. I mean, in summary, if you're having some of these, irritated or tender piriformis region, gluteal region, clients, I know they were tricky for me for a while. So we really encourage you to spend some time, really invest into your differentials a little bit more north into the spine, thoracolumbar area. Really do due diligence, and if you're having radicular pain or it's going down to the leg, make sure you're doing your due diligence, checking out the neurodynamics, and then really just spend some time and looking at how the person moves. So versus just treating the symptom of a sore ass. I think the one good test, or it's not even that, so it's good, is the FAIR test. I don't know if you have that available, but it's flexion, it's side lying, it's flexion, adduction, and internal rotation. If that really lights them up, then it's probably more like that true Piriformis syndrome. And there's a Piriformis activation test. But most of the time I've done that test, and it's not like, it might be sore uncomfortable. You got to look at the joint as well. But it doesn't usually reproduce their primary pain. So, definitely, as I said, and we said it, time and time again, make sure you check proximally. But I felt like just throwing that in to the mix. If you have any questions about those tests or anything like that, shoot us off email or text or DM. We're at Manips and Sips on Facebook, Instagram, and Twitter now. I'm gonna get that going. I know that's big for social media. I'm at The Decent Doctor and at Trifecta Therapeutics. Brandon's at Pursue PT Now and Think Like a Fellow. Some of these things were, start up by questions in our mentorship group. Brandon, I don't know if you want to chime in a little bit about that.
If we're gonna make a quick announcement, we are rocking and rolling with our mentorship group. We have handful of signups, and I was just talking to a couple other people looking to sign up too. Just a quick screen share, since I actually did finally find what I was looking for. This is our manual therapy mentorship. We get to pose questions, or you guys get to pose questions. Myself, Jeremy, and Kyle, who's been our guest on our show, will answer. With our experiences, utilizing research, utilizing what has been kind of passed down to us as well, how we critically and clinically synthesize through some of this information to give you a maybe better or different perspective on how to utilize some of this stuff. So this is just a quick screenshot of some of our responses here. I tend to write novels sometimes, so leave anything out, so I added in there. But that's available. It's on my website at pursueptnow.com. We also have an upcoming one-day course in September, I believe the third weekend in September. That Saturday, I believe the 19th, it's an extremity manipulation course. Quick one day. Jeremy and I are teaching it. Fun course going through the whole upper and lower extremity. I think there's about 20 different techniques, as long as supporting research and use cases, utility, and things like that. So hopefully we see a couple people there from this show. And we also have Jeremy's course at his clinic in October. That's on the lumbo-pelvic region. So just wanted to cover those. If you guys are liking our show, liking information, and can make the course, please do. Would love to have you there.
Awesome. All right. Well, thanks for listening in to everyone, and cheers.
Cheers, guys.